Good morning, Dr. Ian.
Morning, Sheila.
And good to have you here today.
Good to be here.
We are talking about the 30 years. 30 years ago when you woke up and said, I need to start a hospital in Uganda. I don't know whether you grew up from here. Just give us a little about you.
Okay. I'm Irish born and came to Uganda actually in 1987. By the way, I have a picture of which was taken of me
When
just before I came to Uganda. Because I came with the church, just for an exploratory visit.
Yeah.
And having never set foot in Africa before, practically never met an African in Ireland, because I was born in Northern Ireland.
Yes.
Yeah. And Northern Ireland had what they called the Troubles back then, from 1967 through the 70s. So it wasn't very safe. It wasn't as if people would come there to settle because there was the IRA and the UDF and so on killing each other. So I didn't know anything about Africa, and there was a church group that was coming out, and so I came along with them in 1987. Before the beginnings of International Hospital, I had been here for about 6 years and started 𝐂-𝐂 Hospital. I came in 88, which was right at the height of the AIDS epidemic. I mean, it was really when Uganda was suffering. People were just dying from HIV. And we worked under Church Mission Society in 𝐓𝐴𝐻. And that again was very badly hit by HIV and TB.
Yeah.
So I came at first just to come for 2 years to do community health work, and then ended up staying for about 6 years, and then founded 𝐂-𝐂 Hospital, which is a community church hospital.
The 𝐂-𝐂 Hospital that is still in 𝐓𝐴𝐻.
Yes, in 𝐓𝐴𝐻. And so that was my sort of introduction to Uganda. It was quite emotionally traumatic, actually, that time. That's the period I wrote the book, The Man with the 𝐂 𝐆𝐫𝐢. That set the foundation for me for coming back to Kampala. I also had got sick myself. I had cancer, and it was touch and go if I would recover.
Sorry.
So when I did recover, I couldn't settle back to life in Ireland or Britain. So I thought, let me just come back out to Uganda. And at that stage, Uganda was really, things were very optimistic because society was being rebuilt again after the Civil War. And there were corporate organizations beginning. There was banks, and there was industry was moving. And I thought, well, this developing country, rather than just depending on handouts for medical care, could, if we get people to pay for the medical care and then reinvest that back, one could actually build a private hospital and build something that was long-term sustainable. So that was my thinking when I settled back in Kampala. So I thought, I'll just start a clinic. When you start a business, you're going to sell a product or a service. Yeah. And the service I was selling was myself. The service was Dr. Clarke in his clinic, being there to treat his patients. And I called it International Medical Center. The first day I opened the clinic, I had one patient.
You had one patient on the first day.
And then when I would have 3 patients, it was like, that was a good day.
I would be interested in seeing that first patient that came to your clinic 30 years later.
He walked in, I think I can still remember who it was. And then, but then the thing is, it grew quite quickly because I was very determined to be consistent in what I was offering. And I had also formed the opinion, having worked in Uganda in a rural area on a mission hospital before that, I believed that Uganda didn't have to have poor medical services where it was unhygienic and the diagnoses were inaccurate, that you could do something that had quality, which didn't have to cost the earth, and I believe people would pay for it. And I think that's still the philosophy that flows through 𝐂-𝐶 𝐓𝐴𝐻𝐾.
Yes.
We will give you quality, you'll have to pay for it, but you can rely on it.
That is true.
So that was right from the first.
That is interesting. So should we say, Dr. Ian, when you were coming to Uganda, before you went back, did you have some money, or you looked at the opportunities and went and looked for money to come?
I went and looked for money. So when I came out in the 𝐂-𝐂 period, I was sponsored by Church Mission Society. It was a very historic and famous mission behind the Anglican Church. But when I came back again, it was on my own prerogative. And so I had to raise money. So I actually took a mortgage on my house, or took an extra mortgage on my house. And that was the sort of money I put into it. Because I remember it was about $70,000 at that time.
$70,000.
That I sort of first, of my own money.
Yeah.
That I put in, because I needed to furnish the clinic and all that sort of stuff. But then, as far as the hospital was concerned, now my ambition, as I say, was to do quality healthcare that would pay for itself, and then I could reinvest the money.
Yeah.
And my goal was to build a hospital. And within quite a short period, I then obtained a lease on an old building.
Yeah.
And negotiated with these sort of 3 or 4 old Indian men, and they say, you know, basically they argued among themselves in whatever language they were speaking, and then we finally agreed a long-term lease for that building. So I got the building, which was quite dilapidated, and then I had to plan to put a hospital inside that building. So that was the first iteration of International Hospital, and it was on Old Kampala.
Yeah.
That building wasn't ideal, but it still could house like 30 beds, and we were able to fit in a theatre, realised we needed a mortuary. The landscape was such that although we made provision for a lift, because it was a 2-story building, we were able to, there was a sort of ramp as well. The first money I put in myself. And then as I built up the practice, then patients started to come. And I did have a surplus, and then I was able to put that into renovating that building. But, so this was around about 95, 96, 95. And then I got cancer again. So that was really a bit of a disaster, because I was, you know, if you're selling a product and you are the product, and then you take yourself off for 6 months treatment back in Ireland, it was a bit of a disaster for the whole thing. Now, fortunately, I had one doctor working for me, so he was able to keep things just ticking over. But that was a very, very difficult period, because the first cancer had been serious, the second one was just as bad, and also I was going through really horrible chemotherapy.
I can imagine.
So I was out of the country for 5-6 months. I used to keep, between periods of chemotherapy, I would come back to Uganda until one day when I went back, and the consultant oncologist was standing there at the end of the bed saying, "You're not going back to Uganda." So anyway, so I got through that. I came back completely bald because I'd lost all my hair, and people didn't recognize me. And tried to pick up the pieces, because literally the practice had really gone down while I was away, because I wasn't there.
Yeah. And you were away for 6 months?
It was about 6 months. Oh, and then I came back, and just as a welcome back, the Uganda Revenue Authority decided they would shake me down as well. So I remember that. It was just a bad, difficult time. And at the same time, I started to build the first international hospital, because I was in a clinic, and then I was renovating this old building. So that was halfway through. So it was really tough at that time, I must say. So the origins of 𝐓𝐡𝐞 were in some pain.
I can imagine.
Some stuff that went on, but everything you grin and bear it, or you grit your teeth and you get through it. And I had a few young people working for me. I had always this. I just seemed to. There was great young people, nurses or administrators. My own daughter Rose Nanyonga. She worked for me for some time as a nurse, and Pendo Gallo-Kande, who's the wife of Professor Gallo-Kande, who still works for 𝐂-𝐶, she was one of my first administrators.
Oh, really? Yeah. That is nice.
And my management style at that stage was always to sort of, look, you can do it. It's okay, you just do this and this. I'd give them some guidance. I'd show them, what to do, and then say, no, it's okay, you can do it. And that confidence in the people, and since these were young people, often just I'd come out of college. Yeah. The fact that I had confidence in them, believed in them, really made them rise. Actually, I remember once I was, when the hospital got going, the president's, I think it was his mother, was in it. It was really terminal care. And I think it was his mother. And he was out of the country. and then he talked to me on the phone, and she was actually on a ventilator, and he said, will she survive till I get back? And he came back, and the hospital everything was literally packed in to that hospital, and so he came down the stairs, and the security around him then wasn't what it is today. He came down the stairs, and all the nurses and everybody came, and they were all just crowded around him, and we were all just there. And I remember him saying, you've got a nice crowd of young people to go.
And that was the president?
That was the president.
Oh, nice.
Yeah. So it was quite interesting, because one of the receptionists was just sort of sitting in their chair.
Yeah.
I'm like, God, it's the president. So that was the first hospital. And another thing that happened in that hospital was we'd been working with a South African surgeon who could do keyhole surgery, minimally invasive surgery.
Keyhole. I think 𝐂-𝐂𝐀 was the first one to do the keyhole surgery.
We were the first one to do it. We were the first one to do open heart surgery too. So the keyhole surgery was done in the first hospital, and the patient was a friend of mine who was also a famous judge. So Judge Julia 𝐓𝐡𝐞. So she was working in the International Criminal Court at that stage, and she said, no, I don't have time for this, 6 weeks recovery. So she had a gallbladder. She had gallstones. So we said, well, look, we're getting this. We have the equipment. We'd bought, I think, second-hand equipment, actually. But we've got some equipment to do this keyhole surgery. And we had... Moses was involved in it, Dr. Galakandi, but there was a South African surgeon who was a Ugandan working down there, and he was happy to come back and do it. So it was a sort of not a one-off, but the first one we did. And I said to Julia, you'll be like the first patient, you'll be like the guinea pig. She said, it's okay, it's all right. So we did the keyhole surgery, and like literally 2 days later, she sits on bed and she says, okay, I'm going to call a news conference. It wasn't us, it was Julia. She said, I'm going to call it. That's why I can tell the whole story. The patient? The patient said, I'm going to call a news conference and, to let people know. So she called this news conference sitting up in bed, looking great, just having had a surgery like a day before or something like that. And she said, yes, we did this. The International Hospital did this keyhole surgery. What are the rest of you doing? It was a challenge to the government. And what had happened, Moses told me, because Moses was working in Makerere at that point, and he said, the senior consultants in Malago and Makerere, they had used to call us International Private Hotel or something. They were just like really derogatory. They were like, this guy, this is of no consequence whatsoever. And then when this came out that we did the first keyhole surgery, they were shocked. They were like, what? This little place can do that? And then what was even worse, apparently, now Moses told me the story, that they all went to the cupboard in the Department of Surgery and opened the cupboard, and there they had all the equipment to do the keyhole surgery, to do the minimally invasive surgery, but no one had done it.
At the government hospital?
At the government hospital. So they brought the equipment, they were, but they just, the processes were such that they didn't. Yeah. And we went ahead and did it before they got organized to do it at all. So he said it was like a double whammy. First of all, there was this hospital that they didn't rate whatsoever. We were just doing silly stuff, I suppose, cosmetic stuff. And here we were doing serious stuff. So that was our first international hospital. And that was still at Old Kampala. That was in Old Kampala, in this building where I had this long-term lease. And it had 30 beds. And we were busy, and we were, from all points of view, it was a learning curve. Yeah. I remember at one stage, it was a small team, maybe 100 people. We really needed to get our processes in place, learn to be a corporate organization, learn to put KPIs in. I remember once, and I'm sure the nurses didn't, wondered what's wrong with the doctor, because I was the sort of person, I'm quite active, and I would be running around doing a lot of things. And I put these notices up because I was so frustrated with some of more of the nurses. The notices said, think for yourself. In other words, be a problem solver. And the nurses were just looking at the notices and saying, what does that mean, think for yourself? I wanted people who could really solve problems. But we would have we were a team, and there was a sense of we were doing something worthwhile. There was a sense this was a Ugandan organization because we had other expatriates. I remember we had, I think Dr. Alex still works at IHK.
Yes, 𝐂-𝐂𝐞.
Yes, Alex 𝐂-𝐂𝐞.
Alex has been here for 30 years.
Alex 𝐂-𝐂𝐞 rocked up at the hospital, and we had another Russian cardiologist then who used to come and do stuff, and she introduced Alex. And Alex rocked up, and Alex couldn't speak English. And I said to Alex, because he would just say, I think he still says that. And so I said to him, Alex, go away and learn English and come back again. And he did. He said,
he went.
He came back and he could communicate with the patients. He still said, like he wasn't a great talker or anything, but really nice guy.
Yeah,
and he's been there ever since.
He's a very good doctor.
He's a good guy. So we had those sort of people coming off the services because it was hard to get specialist services just out of the Ugandan. So we took, who would come. We stuck with it in terms of at least trying to, have a quality service, have evidence-based medicine, have a decent service to the patient. I mean, I'm really proud of International Hospital now because I go into it and I see the patient care and I see the way the nurses now are professional. Man, it was a long journey to move from, because you see nurses then, the nurses would be the kind of girls that, well, I didn't get the funding to go to university, so I just did nursing. Yeah. So they didn't have a sense of calling or professionalism in it. That's why we started the nursing school, which is today the
nursing school
university. So anyway,
so the university started as a nursing school, and that was it was up. I think it was up there on top of the hospital at that time.
Yes, on top of it was the top floor of the hospital. was the university.
Yes.
But anyway, I was just telling you the story. What happened was then, when we were in Old Kampala, we actually started what the Health Maintenance Organization, basically medical insurance, although it wasn't really medical insurance. It was membership organization. Yeah. And we started that because I was asked by the American Embassy to provide a scheme for their staff, and they said we want to pay you on a capitation basis, so we'll pay you so much per year per person that you look after. So we want you to look after them outpatient yourself. And even at that stage, it was before I started the first hospital. So I didn't even have a hospital, but they said when they go to hospital, then you can attend to them and look after them. So they had to go to Nsambia Hospital and those places. And that we started as IAA Healthcare. Yes. And then that actually grew because we then needed clinics to look after them.
Just Doc, at what point did you start IAA? Which year was that?
Good point. It was around the same time.
It was around after the clinic, between the hospital?
You know what? I think IAA actually opened before IHK.
Oh, it opened before the hospital?
I think so, because I think it was fairly early in the time when I had the clinic. And of course it was like fledgling, but and you see what IAA did, the business model was signed because the IAA brought me in groups of patients. So once the American Embassy came in, I was getting a check every quarter. Yeah. Now I was pretty much able to bank that, to use that check to help to build. Yeah. Because the American Embassy, they had actually gone to other service providers before me, but they were paying something like $160 per patient per year. $160. And other service providers would say, but I can get $40 or $50 per consultation. That means if a person comes more than 3 times a year, I'll be losing money. But what they weren't taking into account was if those people were coming to my clinic, I already had the infrastructure. I borrowed the money for the capital costs. I was already paying the running costs on the staff. Okay. So the only marginal costs I had were the extra drugs and lab tests. So people didn't, from a business point of view, doctors are not necessarily very good business people. They're not trained in that. And but I had some experience of business before I came here. Yeah. And so I realized it was a marginal cost thing, and I was going to actually get some money from it, and it would cover my fixed costs. So then I realized if I grew that, if the American Embassy wanted it, then some banks would want it, and so we basically got a sales team who went out and sold that. And that initially was really, really good for me because I was not only meeting my fixed costs, I was making money, which I was able to plow back in. So my original idea that I could provide a quality health service, medical service, and then put the money surplus back in to building a hospital it became a reality. So that's how we built the first hospital. And we, at the same time as doing that, then started several other clinics. So the network started to grow at that time.
That takes me to my second question. When you built the first clinic, then you went into the hospital and started expanding the network. You know, there is this heart, the mission that you had that made you start this whole thing. At what point did you feel that you're still on track? You're not losing it because you've seen people who really needed healthcare. Yeah. You've seen the opportunities, American embassies coming in. Yeah. You're seeing those other people who are coming in to fund. At what point did you feel that I am still on track and I'm not going to lose the focus when you started scaling?
No, I never thought I would lose the focus. Because I was quite clear in my focus, basically it was the same focus as we have today, which was to provide a quality healthcare service and to raise the level of Ugandans, from a kind of service that will do its Uganda, where people were doing medical practice that was actually wrong, where people were not hygienic in their standards. So I remember someone saying to me, resource poor doesn't need to be it's second rate. Yeah. So you can have a clean hospital. It doesn't cost any extra money. You can do evidence-based medicine. That was a big thing for me because it was a struggle. When I was telling people, you don't have malaria. And they would go to some other clinic and they would say, oh, you've scanty parasites. Oh, we better give you the drip. We better do all that stuff. I struggled for years on that thing. I remember sitting with a company, it was National Environmental Management Authority. And I sat with a bunch of their executives because by that stage, we were doing, they were our members for IEA Healthcare. Yeah. And you see, these people thought that you were trying to save money by not treating. But in fact, what we were getting was a very strongly emerging resistance to the drugs for malaria, because when I came, you could use chloroquine, and then it was quinine, and then we had to go to the artemisinics and so on. So I was trying to explain to them about this malaria, how you need it. You should see parasites. You shouldn't diagnose on, I have a fever, so therefore it's malaria. And the guy who was like high up, a PhD, he said, yeah, well, you're treating malaria the way, the way the London, because I went to the School of Hygiene and Tropical Medicine, and that's the way you treat it. But in Uganda, you treat it our way. We know our malaria. There's no science behind it. And eventually now you find that because you have rapid tests and because people can easily diagnose malaria or not malaria, so now we've shifted to bacterial infection. Complete rubbish. You see people walking around with these cannulas. Yeah, so the cannulas. If you can walk around with a cannula in your arm, then you could swallow the antibiotics. I mean, come on. Yeah. So this sort of treatment by expectation, so the child has got a fever and the mother is worried and she wants you to do something, or treatment for money, this one was completely out with me. But it was a struggle to actually say, and by the way, you still get bad practice, even at IHK, where someone says, oh, I've come to this fancy hospital, so you better give me the most expensive antibiotic. And the person needs paracetamol. But if you send them out with paracetamol, I went there. So that has been a struggle to actually try to change the thinking and the mindset of people that what you need is evidence-based medicine that is actually going to give you the appropriate treatment that you need. And when many of these illnesses are viral illnesses, and when people can run to another clinic and they tell them something different just for the sake of money, then there's a problem. So I struggle with all that, to try and build the good practice, the professional practice. Yeah. And also to have nurses that were up to standard. We ended up sending nurses to India, several Indian hospitals, including I think Fortis, and including there's another big group there. Actually took our nurses. We just paid their airfares. Oh,
that was nice.
They were great.
Yes, that was
and I remember asking a batch of nurses who went, and it was very good for the content. These were registered nurses, so they were well trained. And when they went to India, they said, we realized we were as good as the Indians, except that they had a work ethic that we didn't have.
Oh.
So they said, so when it would come to sort of just going off shift, the Ugandans would be like, okay, my shift's finished, I'm going. But the Indians would be actually continuing, to
get the process of the handover.
But they realized, that the issue wasn't that them as Ugandans, they were actually as smart, as well trained, better than the Indians. But that whole thing of work ethic and standards and so on, they needed to sharpen up on that. And a lot of those girls, they were mostly girls, that were some boys too, but they were some of the first people that staffed our ICU. And really that was again another process. But now the ICU wasn't really open until we got to the new Kampala hospital.
Interesting. Now, Dr. Ian, you talked about when you were starting up, you got cancer. You had to leave the country 6 months, came back, you got another episode, you had to leave again and come back. You came back to URA. Those are some of the things that another person would say, why am I struggling with this thing? I should just let this thing go and do something that can make me money. Right now you're a farmer. You would have thought of farming then.
Don't think I never went into private healthcare for the money. I never did that. It needed to be sustainable. But then even the money that I was making, I was putting it back into the service again. But I mean, in the process, I was able to pay myself. I was able to get a house for myself. So, it's not that I didn't want to make money. It's not that I wanted to be some sort of Mother Teresa or whatever. I wanted to do a sustainable system, but I wanted it to be it was definitely not based on money, because if it was based on money, I'd been doing all those bad practices myself. But I wanted to improve the nursing care. The medical care was fine, but it was lacking in terms of the higher level specialties. Those were hard to get because those people had all fled the country. And I wanted to build systems to have equipment, because you can't have a specialist who has no equipment. Early on, when I had that old hospital, this lovely Indian doctor came to Uganda, and he worked for me. But he was an interventional cardiologist, and he had to leave because we had no facilities for interventional cardiology. And like he said, if I don't go back and practice, I'll just lose my skills. So you had that emphasis as well. Let's try and invest in the equipment, and that was a struggle because you're really bootstrapping. You're really bootstrapping because as a new organization, it's not that banks are coming along and saying, we will lend you money for this. And then also the cost of borrowing was sky high, probably 20% or something like that.
Yeah, 10%, that was quite fair compared to what it is right now.
It was at 20% then.
20%?
Not 10%.
The difference is not.
But I'll tell you what, okay, when I started then when I got the vision to do the current building for 𝐂-𝐂𝐀. So we were working in that 30-bed hospital, and we had one or two other clinics. We were making money, and it was actually a very interesting financial offer that I got. The bank I was with, which was then Barclays, which is now ABSA, they still had some of the white people in it at that point. And there was one guy who still lives in Uganda, I think, Ben Lewis, who told me, we've got this facility from the European Investment Bank where we can loan to you in shillings. And he worked out the rate, my risk, and by that stage I'd been in business a few years. And he said, we can lend to you at 7.2%. That was what they came up with, I think, on the shilling. And we always had depreciation on the shilling at that stage. When I started, the shilling was like 1,000 or to the dollar, 1,200, and then it went to 2,000, so 3,500. So the fact that I could get, even if you could borrow in dollars, then it wasn't wise because you were losing.
Yes, you're going to repay in shillings.
And so this offer of 7.2%.
Yeah, from 20%, that is very fair.
Yeah, I mean that was doable. And he said, we'll loan you $1 million, and that was the money that I started. That
built the 𝐂-𝐂𝐀.
It didn't build it. Of course, it cost a lot more than that to build it. But it was the money that started the journey. So that enabled me to get the land and start the building. And then the business kept expanding.
Yeah.
So that we brought more money into it. But it was, again, that was a struggle because you were bootstrapping. You were making money, but it was all being put back in. But I felt it was a necessary step, because otherwise I'd have been in a building which was just a long leasehold.
Yeah.
There wasn't any real security in that. It was also like a small place. It wasn't really fit for purpose. So that was a big step, moving from a 30-bed hospital to what was then like kind of 100 beds.
100 bed, yes.
Maybe a bit less than 100 beds, but it was like 3 times. 3 times. So that was a step. There have been periods, like the period that I described when I had cancer, and it was hard.
Yeah.
There's always been those periods. There's periods when you're not going to achieve anything unless you push through. But if you have enough belief in what you're doing, and you have a team around you. I told you about starting with these young people.
Yes.
I've always had a team. I've always had people, and that's what's one of the big factors for me. It's Ugandans who supported me.
Yeah.
It's not like I'll bring in these people from outside and we'll do something.
Yeah.
I'll come like the great white savior. You become part of the system. So when I see a staff who's sloppy, it reflects on me, And so if I can tell them, look, it's not just you doing something, but you're affecting the whole team.
Everyone else.
The whole image here. So we would have always regular staff meetings, and there was really a sense that we were changing the face of private healthcare in Uganda. And we did, getting Ugandans to believe in themselves and then have the discipline to adopt the standards and the KPIs. And then, and then going outside for training and coming back and implementing that. It's about having the right team, because this is not Ian Clarke who can do this stuff. It's Ian and Sheila, and Ian and, it's a whole group of people. And getting people to understand the competencies, believe in themselves, and then go ahead and do it. One of the big struggles, and I suppose this comes to, and one of the reasons why eventually I sold on to 𝐂-𝐶, was I never had enough money. I never had the time. I built the hospital, completed that. We were doing some clinics. We were doing a lot of community work as well. There was never enough money. So if I wanted to buy a new bunch of equipment or something, I didn't have the money to do it. And as I say, it's very important. You need the facility. So the facility that we built in the current hospital was a good facility. It had the right air currents. It had the right car parking. It was a good, structurally it was a sound facility. But we would be looking for C-arms, and then sometimes I remember I bought this digital X-ray equipment, which was secondhand. I am telling you, I spent $60,000 in that equipment, and it sat in a box. They were never able to get it, to get it working. And
Why?
Again, I did the same with an MRI.
Why?
Because it's secondhand. Secondhand equipment is bad news.
It's a bad decision.
Bad news. And I mean, I can say that after years and years and years. But that's all we had money for. So sometimes we would be able to get a tower for theatre to do endoscopies, which was sort of secondhand. I remember that one. That worked okay. There was a lot of the stuff that worked, but there was some stuff that didn't. And it was always getting the service contracts and so on. So that was a big restriction on us, just having that money. And because you're talking millions of dollars.
Yeah, you've scaled. Now you're seeing many patients. You've set a standard, and now you have to meet. You have to keep the promise.
Yeah, I believe that 𝐂-𝐶 has been able to take. You have the founders period, the period of the founding and the building to a certain level. Then you have the more. And that includes becoming corporate and all that. And, but then you have the large company like 𝐂-𝐶 that can come in and take it to another level because they have the finance, they have the muscle.
Yes.
And they can borrow money, they can put money in themselves. So I think that's what I've seen. I think my timing in terms of exit was probably perfect. Although there was a rocky time for about 5 years, I would say.
After how many years? 20 years?
Yeah, how long was I in? Yeah, like 20 years, yeah.
20 years.
It was about 20 years, yeah. 20 years from zero to,
Yes.
to an established hospital. But you know that time when we moved, I identified the land. By the way, getting land in Kampala wasn't that easy. And
Even then?
Oh my goodness, yeah, even then, yeah, for sure, yeah.
Okay.
And so I identified the land, I bought it. I didn't have any government help.
Yeah.
Like some people think that, the government helped him.
I would
The
think
70s
so.
helped me or something. Zero, nothing at all.
Yeah.
And I wasn't looking for anything. I don't want to be politically beholden to people.
Yeah.
So I found the land myself. We leveled and cleared that land. Went to South Africa to get an architect. Brought the people up. We looked at the whole thing. There was a friend of mine who worked here. His wife happened to be have an architecture company down in Durban, and did the footprint and the design, and then basically started building it myself. We didn't get a contractor. I mean, I built a lot of things by that stage, but on a small scale. We're fortunate to get another young architect just out of college who came to, and he would look at the technical side. And then there was another guy, Jim Sleeth was his name, who was the sort of site foreman and kept discipline on the site. So yeah, we did well. The building went up well, and we got the building up and we became operational. And that was a big jump from a 30 bed to 100 bed. I remember security staff. We had like 3 security staff at the hospital. Then we suddenly had 10, 12, whatever. And everything scaled like that.
Yeah, that cost
I suddenly found from making money, I wasn't making any money anymore, but it was just, you have that period when you're trying to.
Yes.
And that was tough. My goodness, that was tough. And, we were, I wouldn't say over trading, but it was just that we needed more money into the organization.
Yes.
And it was around that time that I then got private equity.
So at that time, when you got private equity, was it a thought that had come to you to look for private equity, or you just chanced one?
No, I'd had several offers. I mean, there was a hospital group in India that said they wanted to come in and be part of me. And then they were erratic, then they backed out. So I'd had several offers of partnerships. And I did want to partner with an international organization, again, in terms of standards and all that. And the number of sort of procedures you could do. And then essentially this organization, which was called the 𝐂 Fund, which was, they were in combination with another small Kenyan fund. They were about the right size for the tickets, what they call the ticket size of the investment. And, I was fine. And we really needed the money by that stage because we had scaled, we had a lot of costs. We weren't making, I think, as much money at that point as we had been making when we had lower costs.
Yeah.
So the private equity company came in, and I'd never been afraid of, proper structured finance, proper books of accounts. I mean, we kept books of accounts. Everything was above board. Grant Thornton was our auditors at that point. So we were investable. I mean, you find with a lot of Ugandan startups, they're a bit of a mess. And through that whole journey, said in the small hospital, I was the center, I was sending people here and there. But then when we got to the larger things, then we became more corporate and more, the executive team and the HR policy and financial policies and all that stuff. We became ISO certified. And with our board and stuff. So when the 𝐂 Fund came in and they had representation on the board and they punched above their weight, they would be very demanding. But it was no big deal because we'd already been doing that. I was the CEO and the founder and the majority shareholder and all that. But we still worked according to good practice. So I think it was the right time when they came in. And we got extra money into the organization. And we at first, our performance immediately wasn't great. But very quickly, we turned around. We turned around and we were performing well. And so that, at the end of a few years, I can't remember how many years, it could have been 4 years, or something, quite quickly, then the 𝐂 that's when Jean-Pierre, who's the chairman of is it the SEAL, the chemo fund was linked to the SEAL company.
Oh, okay.
So they knew how the hospital was performing.
Yes.
And then, so he came and made me an offer. They wanted to then get more seriously into the healthcare space.
Yeah.
And after a board meeting, he said, let's have a walk in the car park. And I didn't know what the walk in the car park was about. And then he basically, as they say, made me an offer I couldn't refuse. Not that he was pressurizing me, but it was a good offer.
It was a good offer.
It was a good offer. And then by this stage, as I say, 20 years have gone by. I've already worked in Uganda for, what's that then? Almost
26 years.
Years. I've had totally, all my eggs in one basket. So it was not an offer that I could easily pass up and say, I'm going to hold on to this.
Yeah.
But as I say, there was also the need for serious money, like millions of dollars to really up the game
change
further.
Things.
Yeah. So when he made the offer, I sold out basically 90%, kept 10%, stayed on as chairman to try and shepherd them through a period. Maybe that didn't work because it was a very rough period for the first 5 years, I would say, when SEAL took over.
Yeah,
but
the
I think
transition
actually
was
you
tough.
branded as 𝐂-𝐂 how many years ago? About
10 years?
No, when you branded as 𝐂-𝐂.
That was 3-4 years. Official branding 3 years ago. The other first phase was 1 year, so 4 years.
4 years. So I would say, the real growth and positive establishment has been in the last 5 years.
Yeah.
For 𝐂-𝐂, because the first 5 years were definitely a transition and a rough period. A lot of people left. Some people said, we will never forgive you for selling the hospital. There was a lot of personal loyalty to me.
The emotions, they were there for quite some time, and they were emotionally attached to the hospital.
Yeah.
I would imagine, did you have the same attachment to the hospital?
I don't have that founder syndrome thing. A lot of people think, because the first hospital I started in 𝐂-𝐂, it was a very emotional period. There were so many people died. I wrote a book about it. It was a very intense period.
Yes.
But I was, when it came time to hand it over, I did. But I've stayed involved in that hospital just at the board level to try and help them with finances and so on. And with 𝐂-𝐂, I also still on the board and just as a local person who can help. So I sort of maintain an attachment, but not that sense of I must own this. Yes. I'm happy to see development happen because my overarching motive is to see Uganda develop.
Yeah.
And so I'm not an NGO person. I'm not a development specialist. But when you're building something, that's going to be that's significant in the country, and 𝐂 is significant in the country. When it was wobbly after I left, I was obviously very disappointed at that stage. I'm very happy to see, when they brought in more serious management, the hospital began to build to what it should be again. So now, when I look at the investment that has been made,
yes,
I think as I told me, like $20 million in the last couple of years.
Yes,
that's significant investment. So you're taking a hospital, and now it's been both infrastructure and equipment and expansion of clinics, and I still see the same theme. Let's produce quality of care, and then we'll charge for it. But do you know what? In that whole process, obviously 𝐂-𝐂 focused on the provision of the service, which is great, and exited from the model that was very good for me when I started the health membership organization. That was very good to start with, but it became more regulated. It became just not the field of health service. It was a different thing. Having exited that, concentrated on the service provision, I think they've gone from strength to strength. But they could be making the money and just pulling it out of the country. They're making the money and putting it straight back in to what they're doing. So it's a mark of belief in Uganda, belief in the people, providing that opportunity for people for their own career development, the staff, and then they're providing services in many cases which were never available within country. And they're still continuing to reinvest, which is high risk. When you're they put $1 million into an MRI, full $1 million.
That is true.
And the MRI has done very well.
Yes.
But there was no guarantee of that.
Yes.
You know, like, because there's a lot of other services.
Yes.
And so it goes, you know, in terms of the investments, they're putting a new outpatient block. So I think that my 20 years was to build the foundation, was to build the principles on which we operate, build the infrastructure, get it to a certain level, but then it needed to become a corporate.
Yeah.
You know, it needed to become somebody who had a lot more money.
30 years later, what do you see in 𝐂-𝐶 that you saw 30 years ago?
Well, as I say, in 𝐂-𝐶 today, I really see the same emphasis on quality of care, evidence-based medicine, and then also being able to bring the necessary equipment and stuff into that sector. When I look at 𝐂-𝐶 now, they have in-service some things we out-serviced, like say labs.
Yes.
I wasn't sure about the ability back 15 years ago. I wasn't sure that our ability of our labs to go beyond, you know, to give like a platform with reliable results in, you know, tumor markers, in histopathology and all this stuff. So I brought in Lancet Laboratories.
Yes.
And they did a good job in terms of making our results reliable, consistent. But there was a point then when you now insource that.
Yes.
And you have now better than Lancet. You know, you're actually better.
Yeah.
And that was because also in Mauritius they had the lab thing and they knew how to set it up. So, you know, and you've insourced the dental and various parts.
Yeah, radiology, lab, dental.
All of that. It's reliable because you can't there's no point in you getting a spurious diagnosis of scanty malaria or a bacterial infection or some of these vague diagnoses. You know, you want to actually get the real diagnosis and then you get appropriate treatment. And so I'm really happy to see that, and the investment in equipment and the investment in another thing that has taught me actually was the look and feel.
Yeah.
So when you walk into a 𝐂-𝐶 facility now, and of course you built on the IMCs that we had and the IHK and all that, but now they've pretty much all been upgraded to 20th century standards. I am telling you, I can get better service now in Uganda than I can get in Ireland. I can get quicker service. As I say, it's for a few $100s a year. I get I come to a nice modern hospital. I come to a good outpatient department where there's good x-rays and there's good MRIs and there's the theatre I know is totally upgraded as well. I mean, that's great. This is in a so-called third world country. So when I look at what I started with, I can tell you a story actually. I bought, as usual, because I had no money, for the very first x-ray we had in old Kampala, I bought a second-hand x-ray. And it worked. I think I stumbled a bit. The first one didn't work, but then I got one that worked. And there was, but when we were setting that up, before it was working, somebody came to the hospital in labour. And the hospital wasn't really working. It was like a clinic at that point. So I remember delivering this baby. I think I delivered the baby in the x-ray room, which was not an x-ray room. You delivered a baby? Sorry?
You delivered a baby?
I delivered this baby, this baby.
Interesting.
And, as I remember, it was in the x-ray room. That's what brought it to mind.
Yes.
And then I said to the parents said, so what we call it was a boy. So what we call it, and this is sort of a joke. I'm like, oh, you can call me Ian Clarke. And then Ian Clarke.
Was that the first baby?
That was the first baby. He looked me up then after about 30 years. And he looked me up, because the guy was 29, 30.
Yes.
And he came and he said, I'm Ian Clarke, Terry. That's his name. And, you know, and I remember his dad. His dad worked for the American Embassy. It's come a long way.
Yes, it's come a long way.
Well, good.
It's really come a long way. Yes, we're talking about 30 years later, not 2 years later. That is quite a journey. And quite honestly, Dr. Ian has never had this story in its fullness that you've shared today. I would say that we love the humility that you've shared this story with us and with everyone else who's going to be listening or watching this video. Thank you so much. In a few words, 1 to 3 words, what would you say about the 𝐂-𝐶 now that we know?
Well, 𝐂-𝐶 now, I'm proud of it.
Yes.
And I'm proud that my legacy is 𝐂-𝐶. And I don't mind that it's not me who owns it.
Yeah.
I'm glad I built a foundation that others could come along and build a house on. And I'm proud of Helen.
Yeah.
I think Helen has learned. I've seen Helen just grow and mature over the last 10 years. And, you know, starting from really stumbling but then learning a lot from that, to the point where they're at. So I think the team is good. And I think they've also, now they're at a point, and it took them some time to really learn this lesson, but they've now built a team. So they've got people who are proud of what they do. I mean, you're not doing it, Sheila, just, it's another job. Because, if I had wanted to come just and be an entrepreneur, I could have done lots of other things.
Yeah, I want to imagine.
And I think people who are working in a hospital environment where there is stress, it's emotional.
There is.
When a patient dies, like everybody takes responsibility. So I think I'm really proud to see where they've taken it, and they're still going, and the team that they've built, and the spirit that's in the spirit of excellence.
Yes.
And it's not just self-congratulatory, by the way. And I joined Rotary very late, but I joined Rotary. But one of the things I have to say about Rotary, it's very self-congratulatory. It's if they do a camp, if they do something, they're all taking pictures and all that. I'm not saying it's wrong, because they raise a lot of money for good cause. Yeah? But if IHK, if 𝐂-𝐂, if the IMCs, and if it was all sort of self-congratulatory, but when you guys give excellence awards, it's about the people who you've really been audited. And it's people who have tried their level best through that whole year.
Yes.
That's why you see people be getting really excited, because they know the work they've put into it.
Yes.
And that's what it's about, So it's not just like, we want to show ourselves as this. That you get quite a lot of that in the corporate culture. But where I see the spirit of 𝐂-𝐂 providing a legitimate, a service that's really needed in the country, growing the organization, growing the people within the organizations who are Ugandans, and paying well. I was at times I wasn't able to pay very well. I actually existed often in just the passion and the enthusiasm. You guys are well paid now, but at the same time, if you don't have that passion for what you're doing, then it's hollow. And I love to see that, and there's still a bunch of young people.
Yes.
Yeah. So I'm really happy to see my legacy go on, and hopefully when I'm not here, it'll just go on.
It will carry
on. I'd like to 𝐂-𝐂 to conquer the world. I want you to expand in East Africa.
Yeah.
And continue to, because it's on the right basis. Yeah.